So hello, welcome again. I would like to welcome you again in the next important class of renal diseases. So we are doing about renal diseases, and we had covered most of the basic parts which was related to renal diseases. So now we'll just continue our class. Today we'll do something about the glomerular disease. Before that, I'd like to say that my name is Dr. Anil Sharma, and I am an MD pathologist is from AIIMS Delhi. Okay, so basically I'll be teaching you pathology, and basically you can connect with us with at Unacademy NEET PG. Okay, this is our the Telegram channel, and then you can also subscribe to Unacademy. So subscription of Unacademy basically will help you or give you live classes. So up live classes, so basically these live classes are very important one. Why live classes are important? Because live class, like I'm doing live classes, and obviously you will be going to be benefited by live classes, because the images are easy to describe. Okay, they are easy to describe. So basically you can image based learning you can do in live classes, and hence the practical knowledge can be provided you through live classes. So that is very important important thing about live classes. You can interact with the educators. Okay, you can interact with the educators, you can have live polls and leaderboards, and then you can have test series and analysis can be done. Now this is very gold point for me, like basically you give as much as test series, join as much as give as much as test you can give, and that will help you. Basically test series will help you to analyze where do you stand. Okay, so it will say where do you stand, and it will say where, and also it will talk about the how you can improve yourself, okay, so it will answer you where do you stand, it will answer you how you can prepare, how you can improve yourself. Okay, and basically it will just say what all are the things lagging in you. Okay, what all you need to understand more better now. So basically this series will help you to interact and analyze yourself, and you can also clear your doubts live. Okay, you can clear your doubts live. So this is basically important beneficial point of Unacademy subscription. Now coming to the steps how you can subscribe, basically go and click to the Unacademy learning app by typing Unacademy in the Google. Now just go and install this Unacademy app. So you can install the Unacademy app. Then what you can do is basically you can just go and pre-click to the NEET PG section, and over that NEET PG section just get the plus just click the plus section, because you are doing plus, and basically get subscription. Okay, so this way you can get subscription of you can now get subscription of 12 months, 24 months, even 1 month, 3 months, 6 months, 18 months. Okay, so these are the different plus subscription which you can get. And if you use the promo code, like here there is a demo live, so you can use promo code ANILIV live. So this promo code will help you to get 10% discount. Okay, so you can get 10% discount, and this 10% discount basically will help you to get a 24-month subscription in 36,000 rupees and 12-month subscription in 24,750 rupees. So this actually cost you 40,000 rupees. Okay, so this actually cost you 40,000 rupees. How? So basically this is the breakup which you get in plus subscription for 1 month, 3 months, 6 months, 12 months, 18 months, and 24 months. So here for 24 months you are getting 40,000 rupees. So this is basically your 24 months breakup for 40,000 rupees. So this you can get in 36,000 rupees. So you are getting 4,000 rupees. That is around 100 and around 50 rupees per day you are spending. So only 50 rupees per day. Okay, only 50 rupees per day, and you are just getting lot of live videos, live classes, joining test series, and obviously which will help you just to clear NEET PG. Okay, clear your final year exam. So that is also again important thing you need to know. Okay, so let's come to the topic basis. So we have what we have done till now, and what we need to know, basically what we will be doing. So now just today we'll just go for first thing which we will do is let me add one slide here. So basically today what we'll be doing is this is so just we have done different types of what we have done till now, basically when we talk about glomerular disease, so what you need to know is, first thing which you need to know is hypercellularity. Okay, so hypercellularity. So this hypercellularity, so when you know, basically this is, suppose your glomeruli, so suppose this is your glomeruli. Okay, so you are coming, so this is your glomerular, so Bowman's capsule. Okay, so this is your Bowman's capsule. So here you are capillary loops, you have capillary loops, okay, and these capillary loops will have endothelial cells. Okay, and here basically you will have parietals, as what we call it, not parietal cells, visceral cells. Okay, so visceral cells, so this is the parietal epithelium of Bowman's capsule, and there are visceral cells, and obviously here there will be endothelial cells in the capillary loop, and this is the basement membrane of capillary loop, and obviously lobular arrangement. So this glomeruli, they will be lobular arrangement. Okay, so this is basically image which is showing a glomeruli, and obviously they are the endothelial cells. This is the basement membrane, and this is the subepithelial portion of endothelium, and obviously here then there will be mesangium. So here there will be mesangium, and there will be mesangial cells. Okay, here will be mesangial cells. So this is the basic thing. Okay, basic thing which you need to know about glomeruli. And when you know about this, suppose this is basement membrane. Now when you see basement membrane, basically basement membrane will have 3 layers. Basement membrane का 3 layer होगा. So ये basically this is lamina densa. Okay, so this is lamina densa, this is lamina outside, towards outside, this is lamina externa. So this is lamina externa. Okay, lamina externa. What you add? Lamina rara externa, and this is lamina rara interna. Okay, this is lamina rara interna. So this is basically 3 layers which you get in basement membrane of glomeruli. Okay, now this basement membrane of glomeruli, it will be connected with the so your basement membrane of glomeruli with the podocytes. Okay, so here we have podocytes. So these are the food process of podocytes, basically what I say, food process of podocytes. And here basically when I just again if I can draw, so this is a lamina densa. So here you have food process. Okay, and here you will having the cell body of the food process. So this cell body of the food process are large. Okay, cell body of food process is large, so very large. And now this food process basically will be connected with other with एक दूसरे से यहाँ पे nephrin. Okay, so this is nephrin, so this is basically nephrin. So nephrin will connect with this, and obviously this nephrin will connected with this food process by podocin. Okay, by podocin. So this is podocin, and obviously this podocin will be connected with the actin filaments. So this is your actin filament. So actin filament with the help of CD2. Okay, CD2. So these are some of the important structures which connect this food process, and obviously the space between these two food process is known as filtration sheet. Okay, this is known as filtration sheet. So we have done this all filtration sheet. So filtration sheet. Okay, so by now what you know is the Bowman's capsule. So basically this is the PCT. So Bowman's capsule is a reflection of this PCT. It's a reflection of PCT, and obviously there will be glomeruli which will have a vascular end, that is a efferent arteriole, basically an afferent arteriole which is ending over here, and efferent arteriole which is coming out of this. Okay, so basically the place where this efferent arteriole is meeting due to the glomeruli and the efferent arteriole. Okay, this is afferent arteriole and this is efferent arteriole. Okay, so the efferent arteriole is coming out. So basically this place is known as juxtaglomerulus apparatus. Okay, so there will be extraglomerular mesangial over here. There will be extraglomerular mesangial, and this extraglomerular mesangials will have Lecci cell. Okay, so they will have Lecci cell. Okay, they will have Lecci cells. Okay, they will have Lecci cells. So this is basically things which you need to remember about glomeruli, which we have talked with previously. Now when you talk about glomerular disease, then what you need to know is basically whenever talk about glomerular disease, So what you need to know about glomerular disease is, so this is basically a glomeruli. Again you can see a structure. So see, this is your Bowman's capsule, and this Bowman's capsule have you this parietal epithelium. Okay, so it have a parietal epithelium. Then you have all all these are basically what is this? All are your basically capillary loops. Okay, so these are the capillary lumens. These are the capillary lumens. Okay, so these are the capillary lumen, and this is the basement membrane of the capillary lumen. This is the basement membrane of capillary lumen, and the capillary lumen have endothelial cells. Okay, so these are the endothelial cells. These are the endothelial cells, and thus endothelial cells have fenestrated. So these all are the fenestrated endothelium. Okay, they are the fenestrated endothelium. So these are the parietal cells, and obviously the parietal cells, parietal layer, and there's also visceral layer, and this is the visceral layer. Okay, so this the layer which is attached to the basically this basement membrane. So this is a basement membrane. So this layer attached to the basement membrane is known as visceral layer, and obviously these are all the food processes. These are all the food processes, and this is where your visceral epithelium, or what you call it, podocytes. Okay, this is your visceral epithelium, or what you call it, podocyte. Okay, you call it podocyte. So this is about the basic structure of glomeruli. Now you need to remember this structure very well. Now basically this is mesangial, there's mesangial network, basically mesangial matrix, and these are the mesangial cells. Okay, these are the mesangial cells. So these are the basic structures of a glomeruli. Now if you remember these structure, you are done with your renal pathology. How you are done with your renal pathology? See, these are the basic structures. Now we have covered all these structures. Now basically, now first thing what you need to know is, whenever there is a disease in here, this glomerular disease, okay, so there obviously how will the disease occur? So either the cellularity will increase here. Okay, cellularity will increase in the capillary loop, in the mesangial region. Okay, the cellularity will increase. Okay, so basically our cellularity will increase outside here, outside this capillary loop, outside the capillary loop. Okay, the cellularity where will be highly cellular or minimally cellular. Okay, so basically firstly we need to see cellularity, and whichever disease you will describe, now whichever disease you will be describing, the first thing microscopic picture, you will be describing same thing, that it is hypercellular or it's not cellular. Okay, it's either hypercellularity is shown by them, or hypercellularity is not shown by them. Okay, so basically first thing which you need to see is hypercellularity. Now basically I have already discussed about this. So today we have discussed the basic points. So today first thing I'll discuss about is post-streptococcal glomerulonephritis. Okay, so we'll talk about post-streptococcal glomerulonephritis. The first disease we'll talk about is post-streptococcal glomerulonephritis. Now basically we'll go accordingly how we can go on. So see here, this is post-streptococcal nephritis. Okay, so basically we'll talk about post-streptococcal glomerulonephritis, or what I say is it is post-streptococcal glomerulonephritis or post-infectious glomerulonephritis. Okay, post-infectious glomerulonephritis. So this is what we'll talk about today. First thing, so basically now what I say, how we will approach. So firstly we'll see about the glomeruli, and we'll see about the cellularity. So basically what is the cellularity of this disease? So cellularity. Okay, cellularity, what is the cellularity of this disease? So this is hypercellular. We have already talked about that according to hypercellularity. So it is hypercellular. So how we are talked about? So whenever we approach a glomeruli, we see that it is we see the cellularity, and if it is hypercellularity, we see that whether it is intracapillary or it is extracapillary. Okay, we see that it is intracapillary or whether it is extracapillary. So basically intracapillary will define you, intracapillary and extracapillary. So extracapillary matlab capillary se bahar, which we have talked about that extracapillary can be your crescentic. Okay, crescentic glomerulonephritis. Then your intracapillary can be focal or diffuse. Okay, so diffuse. So intracapillary can be focal or diffuse, and in diffuse type we have post-streptococcal glomerulonephritis, membranoproliferative glomerulonephritis, basically lupus nephritis. So these all are the diffuse type of intracapillary hypercellularity. In focal, we have focal segmental glomerulosclerosis. Okay, so basically this is what first thing which you need to know. So the basically hypercellularity in basically intracapillary. So there will be hypercellularity which will be intracapillary. Okay, in post-streptococcal, so there will be hypercellularity which will be intracapillary in case of post-streptococcal glomerulonephritis. Okay, now since you know the first thing that it is hypercellular in intracapillary in post-streptococcal glomerulonephritis. Now other some clinical points is what you need to know. This basically mostly occur in warm climate. Okay, so warm climate, it will occur in warm climate. So basically this can be seen in our country, it can be seen very easily. Then what you need to know about post-streptococcal glomerulonephritis is before reaching the renal, what happened, it can be associated with, so it can be associated with what, throat infection. Okay, throat infection causing by the streptococci, and obviously skin infection. Okay, throat and skin infection. So these are the two common diseases which precedes this post-streptococcal glomerulonephritis. After 3 to 4 weeks, this throat and skin infection can lead to post-streptococcal glomerulonephritis. So now this is another point which you need to remember. Okay, so basically warm climate, throat infection, and that precedes. Okay, so now another important thing is basically when you talk about post-streptococcal glomerulonephritis, then just remember Mumbai ka Dharavi. So now how do you remember Mumbai ka Dharavi? So Mumbai ka Dharavi, what happens in Mumbai ka Dharavi? So there is lot of crowded people, so crowded area. Okay, hygiene is not properly maintained. So hygiene is not properly maintained, area is crowded, hygiene is not properly maintained, and obviously there is malnutrition in those family. Okay, so these are some of the important causes which are responsible for post-streptococcal glomerulonephritis. So what till now what you need to know is post-streptococcal glomerulonephritis is occurring in a warm climate like India. So Mumbai's Dharavi, where there is a lot of crowded people, hygiene is not properly maintained, and there is malnutrition in the childs. Okay, so this is basically most important point what you need to know about this streptococcus. So basically this is caused by streptococcus. Now microbiology, let's connect with microbiology. So how do you connect with microbiology? So basically this is occurring in this already turned off. So basically microbiology, now basically it will cause by streptococcus. So what type of streptococcus? So streptococcus, so which type of streptococcus? Variant 12. Okay, variant 12, 4, 1 and 49. So these are the streptococcus variant which will be causing this post-streptococcal glomerulonephritis. Okay, so these are the variants which will cause the post-streptococcus glomerulonephritis. You need to know this, very important. Okay, so now this is basically about streptococcus. Now whenever we are talking about this kidney disease, glomerular disease, next one thing which you need to remember always is complements. Okay, so complements, so are the complements increase or decrease in this case? So there is hypocomplementemia. Okay, so you can get hypocomplementemia. So this is not a star point over here, but you can get this hypocomplementemia. So basically this is more important. So hypocomplementemia is more important in case of MPGN. Okay, basically hepatitis C associated cryoglobulinemia, hepatitis C associated glomerulonephritis, cryoglobulinemia associated glomerulonephritis. In those, hypocomplementemia is more important than post-streptococcal glomerulonephritis. But when you talk about complements, so you need to know that there will be hypocomplements. Okay, there will be hypocomplement. Then another important thing with this what you get is antibodies to streptococcus antigen. What is ASO titer? ASO titer is basically increased. So this is another important point for post-streptococcal glomerulonephritis. Okay, antibodies to streptococcus antigens, they are increased. That is ASO titer is increased. Okay, so these are the basic points which you know very well, and you have been knowing this all things very well. Okay, so now what is our today's important thing is So what do you get about in light microscopy? Okay, light microscopy में क्या दिखेगा? As I said, light microscopy में now you see glomeruli. So glomeruli में cellularity क्या होगा? They will be hypercellular. Okay, so in light microscopy they will be hypercellular. So hypercellular will be intracapillary. So this will be intracapillary hypercellular. So inside capillary there will be cellularity will increase. So there will be hypercellularity, intracapillary hypercellularity in case of this. Okay. Then okay, so hypercellularity of what? So hypercellularity of what? So basically there will be proliferation of so there is two types. Okay, hypercellularity can be of two types. One, proliferation of native cell. Okay, and then another can be there will be like lymphoplasmacytic infiltration, polymorphonuclear cells, neutrophils and all. Okay, so neutrophils, lymphoplasmacytic infiltration, polymorphs. Okay, that same thing. Okay, there will be polymorphs. So these all are basically inflammatory cells. They can be seen or they can be increasing the cellularity, intracapillary cellularity. Okay, they will be increasing intracapillary cellularity. So now since intracapillary cellularity has been increased, okay, so what happened? The capillary lumens they are blocked. Okay, so the capillary lumens are blocked. So that is another important point which you need to know about this, that capillary lumens are blocked. Okay, so this is about the light microscopic finding of your post streptococcal glomerulonephritis. Now coming to the another important point is like in IF. So what is immunofluorescence? So immunofluorescence in post-streptococcal glomerulonephritis, what it will be immunofluorescence in post-streptococcal glomerulonephritis? So now how we have remembered about immunofluorescence is you need to remember the mnemonics. DAD is MLA. Okay, so I had taught you this way, you just remember this way, DAD is MLA. So you can remember IF of all lagbhag all the types of renal disease. How? See, DAD. So what is DAD? So DAD is basically your linear capillary. Okay, this is linear capillary deposition. DAD is your linear capillary deposition. Okay, so linear capillary deposition. In linear capillary deposition, DAD means D for dense deposit disease. Okay, A for anti-GBM. Okay, like Good's pasture. D for diabetic nephropathy. Okay, D for deposits, that is monoclonal immunoglobulin deposits disease. Okay, MIDD. So basically these are some of the important diseases which you get in basically linear capillary deposition. Okay, this will be linear capillary deposition of IF in these diseases. So you can add one more, that is fibrillary. Okay, then the EASE part is basically mesangial deposit. EASE part is basically mesangial deposit. So in mesangial deposit, what you get is basically in mesangial you get, so mesangial part what you get, I is IgA nephropathy, S is for SLE, basically SLE class 2, SLE class 2. So SLE class 2 have IF on mesangial deposits. Okay, there will be mesangial deposit in this SLE class 2, and basically in this IgA it will be immunoglobulin A deposition. Okay, and in SLE there will be class 2, there will be houseful, that is SLE is houseful. That means your deposition will be of IgA, IgM, IgG, C3, C1q, all everything are deposited, and hence this is SLE basically is houseful. Okay, here this side which I say anti-GBM is basically IgG deposition. Diabetic nephropathy is also IgG deposition. Okay, so now how will you differentiate anti-GBM with diabetic nephropathy? So basically diabetic nephropathy there will be deposition of albumin also, but in anti-GBM there will be deposition of IgG along with C3. Okay, diabetic nephropathy there will be IgG along with albumin, IgG along with albumin. Okay, so this is very important. Then coming to your dense deposit disease, so dense deposit disease there will be deposition, linear deposition of C3. There will be linear deposition of C3. Okay, so this is about your linear capillary deposition, mesangial deposition, MLA. Now this MLA have two parts, that is M and L. M and L is basically your granular, linear capillary, granular. Okay, linear capillary, granular. Now this can be with plus minus mesangium. So there can be also deposition in mesangium also. So M is for membranous glomerulopathy. So this can be basically two types. One is fine and another is basically your coarse. In fine you have M for M, that is membranous nephropathy. Okay, and in coarse you have M for MPGN and L for lupus. Now here lupus is class 3 and 4. Class 3 and 4 lupus has basically your L, that is lupus in the coarse granular glomerulonephritis. Okay, coarse granular nephritis. Now what you need to remember is here this coarse granular glomerulonephritis also have one more point, that is it has coarse granular scattered deposition in post-streptococcal glomerulonephritis. Okay, in post-streptococcal glomerulonephritis also there will be coarse granular deposition that will be scattered one. So some places there will be deposition, some places there will not be deposition. Okay, so that's why we say some kuch jagah pe hai, kuch jagah pe nahi hai. So those places where it have, there it will form like hump, and those where it is not, it will be forming linear. Okay, so it's just basically traveling a road where somewhere this road is smooth, somewhere the road have humps. Okay, then again this road is smooth, again it has humps. So that is post streptococcal glomerulonephritis, hence it is called lumpy dumpy. Okay, so lumpy dumpy, so that's why we call it lumpy dumpy, somewhere lumpy, somewhere dumpy. So this is basically feature which you get in post streptococcal glomerulonephritis. Now you have remaining one more thing, that is A is amyloidosis. Okay, so A is amyloidosis, that is primary amyloidosis. So this primary amyloidosis have all type of deposition, capillary deposition and mesangial deposition, every type of deposition. This is primary amyloidosis. So you can also have fibrillary in this also you can have fibrillary. Okay, so this is basically the rough view of each and every type of immunodeposits which you get. Okay, so just you can remember this table. So now from this table what you get is, when we talk about streptococcus, post streptococcus glomerulonephritis, so post streptococcus glomerulonephritis, so what you are getting in this, so here IF, when I say IF, now from that table you will easily remember that IF in post streptococcal glomerulonephritis is basically your IF from your post streptococcal glomerulonephritis is basically what? It is coarse granular. It is coarse granular deposits, okay, of immunoglobulins. So in post streptococcus it is IgG and C3. Okay, so coarse granular immunoglobulin deposition of IgG and C3. Okay, there can be others also, IgM, IgA also, but maximally this is IgG and C3 post streptococcal glomerular deposits. Okay, so this you need to remember very, very well. So now remember, so another important thing, EM. Now after IF you need to know what EM, electron microscope. So in electron microscope also what we have done in electron microscope, now we know very well कि there will be in electron microscope there will be subepithelial deposition. Okay, so subepithelial deposition there will be, so basically as I said, suppose this is a basement membrane, so basement membrane, so what happen, so this side you have podocytes. Okay, this side, this external rara side you have podocyte, and this side you have endothelial cells. Okay, so basically those anything depositing towards the podocytes and below this line, this is called, they are called subepithelial deposits. Anything depositing towards the subendothelial side, they are the subendothelial side deposit. Okay, and then obviously depositing over here, that is intramembranous deposits, intramembranous. And there can be also deposition in all of the three regions. Okay, and obviously there between this intramembranous, there inside the membrane there can be mesangial. So there can be mesangial deposit. So these are the different types of deposits: subendothelial, subepithelial, intramembranous, and mesangial deposition, or combination of all. Okay, so these are the different types of deposition which you get in case of your electron microscope. Now what is this subepithelial deposition. So subepithelial deposition, you basically where do you get this subepithelial deposition? So you get in membranous glomerulonephropathy. So membranous glomerulonephropathy, MGN, okay. So and also you get in lupus nephritis class 5. Lupus nephritis class 5, okay. So lupus nephritis class 5, and obviously post streptococcal glomerulonephritis, post streptococcal glomerulonephritis. So these are the three major type of glomerulonephritis where you get subepithelial deposit. So in our post streptococcal, where do you get? You get in where do you get deposits? Basically in subepithelial region, okay. So the deposition will be in subepithelial deposition, and hence in subepithelial region they will form humps. Wherever they are deposited, they will form humps, okay. So that hence they are also called lumpy bumpy. So hence they are also called lumpy bumpy, okay. So this is subepithelial. So subendothelial, when you remember, you just remember MPGN type 1. MPGN type 1 is subendothelial deposition. Intramembranous, just remember dense deposit disease. Dense deposit disease, you can just remember a dense deposit disease. So then that is MPGN 2. MPGN 2, okay. MPGN 2. You need to remember. MPGN 3 can be all everywhere. Mesangial, again it is IgA nephropathy, okay. Mesangial, it is again IgA nephropathy, which you need to remember. IgA nephropathy, okay. Mesangial, again IgA nephropathy, and mesangial, that is lupus class 2, lupus class 2. So these are the basic type of deposition which you get, okay. So now basically you know the basic things. So with basic things you are done, okay. Now I just don't need to also teach you everything. You will understand yourself. So post streptococcal, what will be there? EM will be subepithelial deposits, okay. There will be EM will be subepithelial deposits, okay. It's not that in post streptococcal mesangial and subendothelial deposition can also occur, but maximally it is subepithelial deposits, okay. Subepithelial deposits, that you need to remember, okay. So now basically you are done with this. So what are the differentials? What are the differentials of the disease? So basically what I said, मैंने क्या बोला? I said post streptococcal glomerulonephritis is intracapillary hypercellularity. So when I talk about intracapillary hypercellularity, so basically intracapillary hypercellularity. So this intracapillary hypercellularity can be also seen in MPGN, okay. It can also be seen in lupus nephritis. So this you need to remember, it can also be seen in MPGN. So MPGN becomes one of the differential diagnosis. Then you can also see this is endocarditis associated glomerulonephritis, deep seated glomerulonephritis, shunt nephritis, okay. So these are the some of the differential diagnosis of what you call it post streptococcal glomerulonephritis, okay. So now what another last thing what you need to know is prognosis. So prognosis basically is good in case of children's. In case of children it is good, prognosis is good. But what about the symptoms? So nephrotic syndrome and nephritic syndrome. So nephrotic syndrome, remember nephrotic syndrome, that is proteinuria, okay. Proteinuria and hematuria, it persists for longer period of time, okay. It persists for longer period of time, and subepithelial and neutrophilic disappears from 6 to 8 weeks. Subepithelial deposits, they will disappear and 6 to 8 weeks. Yes, 6 to 8 weeks में disappear हो जाएगा. Subepithelial deposits will disappear in 6 to 8 weeks, and obviously they can also undergo spontaneous recovery. So they can also undergo spontaneous recovery. So they can also undergo spontaneous recovery within weeks or months. So these are different. These are the important things for post streptococcal glomerulonephritis. Okay, post streptococcal glomerulonephritis. So now what we have done? We have done post streptococcal glomerulonephritis. So basically now after that post streptococcal glomerulonephritis, we also already have completed. We had previously completed membranoproliferative glomerulonephritis, as I think. Okay, membranoproliferative glomerulonephritis, we had completed membranoproliferative glomerulonephritis. So So in membranoproliferative when we talk about membranoproliferative glomerulonephritis, I think we have not completed that. Okay, so when we talk about membranoproliferative glomerulonephritis, so what we need to remember is just remember I'll keep one over here. Okay, so when I say membranoproliferative glomerulonephritis, what you need to know is about in membranoproliferative glomerulonephritis. So membranoproliferative glomerulonephritis can be type 1, type 2, type 3. Yeah, that is importantly you know. So type 1 is basically the basic type of membranoproliferative nephritis which we study. Type 2 basically at present it is included in C3 glomerulonephritis. Okay, so basically previously MPGN was classified as type 1, type 2 and type 3 MPGN. Now type 1 and type 2 MPGN have been classified into C3 glomerulonephritis. Okay, glomerulonephritis. The C3 glomerulonephritis, also known as dense deposit disease. Okay, also known as dense deposit disease. Okay, so this you need to remember. And obviously there is type 3 glomerulonephritis. Now basically the type 1 have hypercellularity, and this hypercellularity is what is the hypercellularity here? So in this hypercellularity, type 1 hypercellularity, there will be intracapillary hypercellularity. Okay, there will be intracapillary hypercellularity. So intracapillary hypercellularity will be seen in case of type 1 MPGN. Okay, so basically this was about the cellularity. Now because of this intracapillary MPGN type 1 hypercellularity, you can see tram track appearance. Tram track appearance. So how do you see tram track appearance? Because the mesangial cells, so suppose this is the capillary loop with basement membrane. So this is the capillary loop with basement membrane. Okay, so this is capillary loop with basement membrane. So here you have the mesangium. Okay, so these are the mesangial cells. So what happens? These mesangial cells sometimes they interpose between this basement membrane and capillary loop. Okay, basement membrane and capillary loop. So they will interpose between this. So this is, so here they will interpose circumferentially. ऐसे circumferentially interpose हो जाएंगे in mesangial cells. Okay. So now what do you get from this? Okay, what do you get from this? If you say street, so there is something like this. So what is this? This is tram track, no, railway track जैसा कि यहाँ बीच में एक वुडन बना होता है, यहाँ पे स्टील का इधर और इधर एक स्टील का वो pathway. So ये basically, so this is called tram track appearance. So because membranoproliferative glomerulonephritis में और tram track appearance क्यों होता है? क्योंकि सब mesangial cell interpose between the capillary basement membrane and the endothelial cells. Okay, basically between them this interpose बीच में आ जाता है ये mesangial cell. Okay, so this is basically the main cause of MPGN. So MPGN का most important main cause यही है. MPGN type 1 हो गया. ठीक है, type 1, type 2, type 3 में भी दिख सकता है. So which we are not concerned about that basically. But type 1 type 1 is more important because this is main type of MPGN which you see. IF, now I don't need to say IF कौन से पार्ट में आ रहा है? So ये कौन से पार्ट का? Dad is MLA. So ये M वाला पार्ट का है, MLA M वाला पार्ट है. तो इसमें MPGN में कौन सा था? Basically it will be coarse granular type. Okay, so IF will be coarse granular type. So IF will be basically coarse granular type of IF. So coarse granular type of IF. So that you need to know. So coarse granular किस चीज का डिपोजिशन होगा? C3. ओके, मेनली C3 का डिपोजिशन होगा. MPGN में बेसिकली C3 का डिपोजिशन होगा. Okay, there can be deposition of other immunoglobulins like IgG, but maximally it will be of C3 deposition. Okay, so there will be maximum deposition of C3 deposition होगा. ठीक है, C3 deposition होगा. Now coarse granular linear capillary. Okay, so coarse granular linear capillary deposition होगा. There can be mesangial deposition also, but more or often it is coarse granular linear capillary. So अगर coarse granular linear capillary होगा, जैसे capillary loop में यहाँ हो गया, यहाँ पे हो गया है ना, यहाँ पे हो गया. So how do this see this coarse granular linear capillary? So along the glomeruli, so it just looks like a ring. It just look like a ring. So it forms a mesangial ring. So इसमें क्या होगा? Mesangial ring दिखेंगे, mesangial rings दिखेंगे. ठीक है. So tram track appearance, IF में there you can see mesangial rings, okay, mesangial rings. In IF you can see mesangial rings, okay, mesangial rings. In IF you can see mesangial ring. That you need to know. Then EM in electron microscope. So in electron microscope, so basically more common of mesangial ring कौन सा में ज़्यादा common होता है? In dense deposit disease. So mesangial ring is more common in dense deposit disease, okay. So mesangial ring is more common in dense deposit disease, that you need to know. So mesangial ring is more common in dense deposit disease, that you need to know. Now again, as I said, each and every kidney disease, what you need to know? You need to know complement. So there will be low complement, there will be low complement in this disease also, okay. ठीक है. So this is about MPGN. Now what you need to know about MPGN another, when I talk about MPGN, what I write MPGN like this, okay. I write MPGN, MPGN, okay. So what is this? This is basically like C, okay. So basically MPGN is associated by hepatitis C virus, okay. MPGN is most commonly associated with hepatitis C virus. MPGN is associated with cryoglobulinemia. It is associated with cryoglobulinemia, okay. Then also you if you look as a whole, this part as a whole, it looks like E also. So it looks like E also. So basically this look like E also. So basically it is endocarditis. So MPGN can also be seen in endocarditis associated GN, okay. Endocarditis associated GN. So this is basically M, but it also looks like H here. So you can see hepatosclerosis. In hepatosclerosis, you can also see in hepatosclerosis, you can see so in hepatosclerosis also basically if MPGN is induced by hepatosclerosis, so in MPGN what you get mostly C3 deposit. In hepatosclerosis you just get IgA deposit, okay. Hepatosclerosis you get IgA deposit. Then obviously this is basically like L, okay. This is basically your L, okay. So and this is basically your C, ulta C, okay. So LC. So basically lecithin lecithin cholesterol acetyl transferase deficiency. Okay, so you need to remember these important things about MPGN, okay. And MPGN, there will be membranoproliferative glomerulonephritis, okay. So there will be tram track like appearance, okay. Tram track like appearance will be there in IF and basically EM and even in your microscopy, So these are basically your important. And obviously MPGM is hypercellularity, intracapillary hypercellularity. So is what will be DD, post streptococcal glomerulonephritis will be DD. All other, this all are also the DDs of this MPGN, okay. These all are also DDs of MPGN, okay. So these are most importantly, whenever I talk about MPGN, no, you need to remember that endocarditis associated glomerulonephritis, deep-seated abscess and endocarditis is deep-seated abscess, okay. Deep-seated abscess and basically your sont nephritis. So these are basically mostly associated with MPGN, okay. These are mostly associated with MPGN, okay. So this is another important thing which you need to remember. Then obviously IF, where we have talked about IF of MPGN, okay. So here you can see hypocomplementemia, which I have already discussed about this, okay. And another important thing what you need to know is most common nephritis associated with young people, okay, children. So it is basically idiopathic and disease cause present in childhood. So it is most common nephritis in child, okay. Nephritis in child is membranoproliferative glomerulonephritis, okay. So that you need to remember one other point. So basically we have talked about this MPGN1. So MPGN1 basically it is MPGN1 is mesangial hypercellularity, and there will be the deposition will be electron microscope also subendothelial deposit, okay. We have talked about this subendothelial deposits. So subendothelial deposits MPGN में हो सकता है, lupus glomerulonephritis में हो सकता है, ठीक है. lupus glomerulonephritis में हो सकता है. And duplication of GBM दिखेगा इसमें, that is tram track appearance. MPGN2, as I always talk about, this is dense deposit disease, okay. And obviously there will be hyperdense deposits, and in this there will be deposit in be intramembranous, okay. इसमें intramembranous deposit होगा. And MP3 is basically prominent subepithelial deposits and diffuse intramembranous deposits, okay, into MPGN 3. So this you need to remember. And we have talked about C3 glomerulopathy, that basically C3 glomerulopathy are those which will show prominent C3 deposition by IF and electron EM, but very less amount of immunoglobulin deposits or no immunoglobulin deposits, okay. So this is C3 glomerulopathy, where you will see dense deposit disease, okay, dense deposit disease, and also you will see C3 glomerulonephritis. So these are two important glomerulonephritis you see in case of dense what you call it, C3 glomerulopathy. So this is again, see, you are classifying this disease according to C3 glomerulopathies and basically MPGN with immune complex deposition. So MPGN is basically type 1 and type 3, and C3 glomerulonephritis is basically dense deposit disease, C3 glomerulonephritis, familial C3 glomerulopathy, CFHRF5 nephropathy, atypical acute glomerulonephritis. So these are important names which you need to remember in case of C3 glomerulopathy and idiopathic membranous glomerulonephritis, okay, that you need to remember. So basically these are some of the important types of diseases which you call which we get. And now coming to the another type of important disease. So we have talked about IgA nephropathy also. So these are some of the basically MPGN. So what is MPGN? MPGN is intracapillary, ठीक है. तो यहाँ पे देखो कैपिलरी लूप नहीं दिख रहा है, ठीक है, यहाँ पे कैपिलरी लूप नहीं दिख रहा है. ऑल द कैपिलरी लूप इज बेसिकली कंप्लीटली सेलुलरिटी से भर गया है. सो मस्ट ऑफ द कैपिलरी लूप हैव बीन इन फुल्ड बाय द or closed by the cellularity. So cellularity have increased, okay. So this is basically there is high amount of intracapillary mesangial cellularity in this case. Then this side, when you see here, you can see duplication of the membrane. So here you can see the membrane have duplicated. So membrane have duplicated. So mesangial cell interposition between the GBM and the endothelial or visceral layer is what you call it, duplication of the membrane, okay. So duplication of membrane can be seen, and basically they can also show crescent like formation, okay, crescent like formation, which is we see in extracapillary deposition. And we know very well that there will be IgG, and basically there will be more of C3 deposition, and C3 will be deposited in MPGN is coarse granular intracapillary, and there can also be mesangial deposition, okay. And in case of subendothelial deposits, there will be some subendothelial deposits in case of electron microscope in MPGN. So that we have talked about, okay. Now coming to the another important so we have talked about all this previously also, so I'm not talking again and again. And now what you need to remember about DDD is that is dense deposit disease. So dense deposit disease, they are basically those which show C3 deposition within GBM, okay, C3 deposition, okay, within GBM, mesangium, Bowman's capsule and tubules, okay, tubular basement membrane. So now basically what is here the important point here about this dense deposit disease is basically that in IF you can see there is IF dense deposit disease. What is there will be dense deposit disease. So dense deposit disease comes under DAD. So DAD is basically linear capillary deposition, okay, linear capillary deposition more commonly, okay. So you have linear capillary deposition. So when you have linear capillary deposition, okay, then you can have what you can have, you have garland like feature in this, okay, garland like C3 pattern होगा इसमें, ठीक है. So that is important, garland like in dense deposit disease, okay. Now coming to the ribbon like or garland like, and you can also see tram tack appearance also. So then you have another disease which is very much important in IgA nephropathy, okay. So when you talk about IgA nephropathy, by now you know very well IgA nephropathy basically coming with the nephropathy. So the cellularity basically in this IgA nephropathy will be very less, मतलब minimal cellularity होगा. And obviously IgA nephropathy is characterized by hematuria. It is a nephritic syndrome, hematuria with association of IgA deposition basically where in mesangium, okay. Now what do you need to know? It is the most common form of glomerulonephritis worldwide, okay, and it has more of male predominance and a peak incidence in the second and third decade of life, and familiar clustering is very less. But also you can see some of the familiar clustering आप देख सकते हो according to the geography. the geographical region. Okay, according to geographical region, you can see some of familial clustering in IgA nephropathy, and hence that effect is known as founder's effect. So you can see founder's effect in case of IgA nephropathy. Okay, so IgA nephropathy case mein founder's effect, because most of them is sporadic disease, but it can, some of the disease they can show familial predisposition according to the geographical region. Okay, now it is very closely associated with Henox Iscoli and purpura. So basically in Henox Iscoli and purpura there will be basically prominent systemic symptoms. It will occur at a younger age and precede infection and abdominal complaints previously. So in these all are the conditions where you see IgA deposits. In these all are the diseases like chronic liver disease, Crohn's disease, gastrointestinal adenocarcinoma, chronic bronchitis, idiopathic interstitial pneumonia, dermatitis herpetiformis, mycosis fungoides, leprosy, ankylosing spondylitis, relapsing polychondritis, and Sjögren's syndrome. So these are some of the diseases where you can see IgA deposit. Okay, IgA deposits. Now IgA deposits, so you can see basically this is one can be associated with a genetic factor. Another is basically associated with abnormal glycosylation of IgA1, autoantibody to galactose deficient IgA1, abnormally activated IgA response. So these are the most of the causes of deposition of IgA. So basically in clinical scenario, what you need to remember, there will be recurrent episode of macroscopic hematuria during immediate follow-up on an upper respiratory infection. Okay, following an upper, so there will be upper respiratory infection and then there will be macroscopic hematuria after that. Okay, so this is most important, very important two things which you need to see in case of IgA nephropathy. Firstly, there will be upper respiratory infection and then there will be macroscopic hematuria after that. Then you have proteinuria or persistent asymptomatic microhematuria. So basically nephrotic syndrome is very uncommon in this symptom, but it is nephritic syndrome which you can see. And proteinuria can also appear late in the course of disease. Early disease presents with acute renal failure and rapidly progressive clinical pictures. Okay, so this is very much important. Now, most common cause of glomerulonephritis worldwide, we have talked about this. And what happened there? There will be increased circulatory serum IgA in these conditions. Okay, the main symptoms is hematuria with or without proteinuria. Whether proteinuria occurs in late, and it reoccurs in transplant in 30% of the cases. Okay, this is another important thing which you need to know, कि transplant में recurrence कितना percentage है. So IgA nephropathy have a 30% recurrence. Focal segmental glomerulosclerosis have even higher percentage of recurrence. Okay. So basically microscopy, what you say, again when I am talking about IgA nephropathy, I say there will be mesangial hypercellularity in this, and obviously there will be increase in the mesangium. So IgA nephropathy is all about mesangial region. Okay, so IF will be mesangial immunofluorescence, and basically crescents they can be present. Okay, crescents they can be present, and basically you can see the cellularity can be focal or segmental anyway. IF will be mesangial deposits, IgA will be mesangially depositing. Okay, others there can be C3s, IgG, IgM, C1q, anything. And EM there will be amorphous electron dense deposit in mesangium. Okay, so this is mesangium, IgA mesangial deposits. Okay, and basically what you see, you can also see subepithelial and subendothelial, but major is mesangial deposition in IgA. So see, this is IgA. So here you can see type A mesangial deposits are, you are seeing mesangial deposits, higher amount of mesangial deposits of IgA in case of, and amorphous mesangial deposits in case of amorphous mesangial deposits also in case of what you call it, EM. Okay, in case of EM. Then now the next important disease is lupus nephritis. So before going to lupus nephritis, what you need to know? You need to know about systemic lupus erythematosus. So basically lupus nephritis is a presentation of SLE. SLE basically is an autoimmune disorder. We know very well. It's an autoimmune disorder which is basically manifested by inflammation of skin, joint, kidney, and central nervous system. So these are the major parts which are infected by SLE. So basically in kidney you are going to get lupus nephritis. Okay, So basically the main pathophysiology is IgG autoantibodies is formed against DNA, RNA, protein and phospholipids, and hence this is autoimmune disease. Okay, so these are the some of the diagnostic criteria. So basically any combination of 4 or more criteria with at least one in the clinical and one in immunological. So you have clinical manifestation and immunological manifestation, and then there should be 4 such criteria or 4 things should be matching. So one should be from clinical, at least one should be from clinical, and one should be from immunological manifestation. Okay, so basically in skin, what you get in skin, you can get acute, subacute cutaneous LE, which is photosensitive. Okay, malar maculopapular rash. Okay, you can see chronic cutaneous systemic lupus erythematosus. So chronic cutaneous lupus erythematosus, here you will have discoid lupus or paniculitis. You can see lichen planus like also in the skin infection. Hypertrophic verrucous chilblains also can be seen in case of skin infection. You have oral and nasal ulcers, non-scarring alopecia. Synovitis is present in greater than 2 joints. Serositis is present. Pleurisy and pericarditis. In renal, creatinine is protein to creatinine ratio is greater than 0.5. You have RBC cast, and you can also do biopsies. So in biopsy, what we will see is lupus nephritis very soon. Then you have neurological symptoms like seizure, psychosis, mononeuritis, myelitis, peripheral or cranial neuropathies, and acute confusional states. You have hemolytic anemia. You have leukopenia, lymphopenia, and thrombocytopenia. Okay, so basically you have basically in SLE what you have pancytopenia. So leukopenia, lymphopenia, and thrombocytopenia. Now in immunological, you have ANA, which is greater than the reference value. Anti-double standard DNA, okay, that also increase. Anti-Smith, that also increase. That is anti-phospholipids. Any of the lupus anticoagulants is increased. Okay, then you have low serum complements, and you have positive direct Coombs in absence of hemolytic anemia. Okay, so these are some of the important criteria, diagnostic criteria in case of SLE. So again, these are some of the extraskeletal manifestations. So these are the manifestations which you see in case of SLE. So you can see musculoskeletal manifestation, cutaneous, hematological manifestation, neurological, cardiopulmonary, renal, gastrointestinal, thrombosis, and ocular. Okay, so these all are the different types of manifestation you get in SLE. So you need to remember these all things. Okay, you can be asked in exam. So this is basically for integration process. So basically SLE, when you talk about SLE, please learn this all things about SLE. Okay, so now coming to the what our major aim will be, lupus nephritis. Okay, so here again the antibodies like anti-nuclear antibodies. So anti-nuclear antibodies based screening test, it provides a base screening test. Okay, and repeated negative test by IF makes SLE unlike. Then you have anti-double standard DNA. So this is basically high titer and it is SLE specific. So anti-double standard DNA is SLE specific. Okay, SLE specific. Then anti-Smith, basically it is basically specific for SLE. Specific for SLE is anti-Smith, more than that of double standard DNA also, but highest percentage you get of anti-ANA in SLE, then anti-double standard DNA, then anti-NAP, RNP. Okay, then RNP. So this is again another type of anti-nuclear body you can see in SLE. Then you can see ROLA also, which basically more common is associated with Sika syndrome. ROLA with neonatal lupus, it is associated with neonatal lupus. Okay, anti-histone with drugs. Okay, this with associated with drug-induced lupus. So can be associated with SLE also. Then anti-phospholipid, so APL, anti-phospholipid syndrome, you can see this. Anti-erythrocytes can also be seen. Anti-platelet, and also you can see anti-neuronal, including anti-glutamate receptor 2, and you can also see anti-ribosomal P. So these are some of the immuno antibodies which you can see in case of SLE, where you need to the remembrance, you need to remember of ANA, you need to remember anti-DNS, and you need to remember anti-Smith. Okay, anti-Smith is most specific for SLE, anti-DNS is highly specific, anti-ANA is basically most higher amount they are positive. Okay, so what you need to know about the lupus nephritis. So now basically when we talk about lupus nephritis, see lupus nephritis, I have already most of them I've talked about lupus nephritis. So basically it is a common and serious complication of systemic lupus erythematosus. So results from deposition of circulating immune complex. Okay, they are resulting from the circulating immune complex. So this circulating immune complex, what they will do, they will activate the complement cascade, which will lead to complement mediated damage. and then there will be leukocyte infiltration, activation of procoagulant factors, and release of various cytokines. Okay, so this is done by immune complex. There are also in situ immune complexes. So this is against the circulating complex, which formation following glomeruli binding of nuclear antigen, particularly necrotic nucleosome, and also play a role in renal injury. Then there are presence of anti-phospholipids antibody that triggers the thrombotic microangiopathy in minority of patients. Okay. So the most important thing which you see in lupus nephritis is proteinuria. Okay, proteinuria, hematuria, hypertension, and various degree of renal failure and active urine sedimentation with red blood cell cast can be present. Okay, serological abnormalities are common in lupus nephritis. They are not diagnostic. Anti-double stranded DNA antibody basically is seen in presence of renal disease. Hypocomplementemia is common in patient with acute lupus nephritis. Okay, and if hypocomplementemia or complement, reducing complement means there is flaring of the infection. Okay, flaring of SLE का flaring हो जाता है, SLE और बढ़ जाता है अगर complement घट रहा है तो. So this is basically different classes or division of lupus nephritis. So you divide them into 6 classes, class 1, 2, 3, 4, 5 and 6. Okay, so basically 1 and 2 they are basically minimal mesangial and mesangial proliferation. ठीक है, class 3 is focal nephritis and class 4 is diffuse nephritis. Class 5 is membranous nephritis and class 6 is sclerotic nephritis. So basically here more than 90% of sclerosis you can see, 90% of sclerosis. Membranous nephritis, basically membranous nephritis is thickening of the membranes but hypercellularity is less. Okay, so thickening of the membrane with hypercellularity less. Now membranous nephritis, when I say IF कहाँ पे होगा ये MLA वाला M में है, basis membrane nephritis, that is fine granular immunofluorescence. Then you have electron microscope. Membranous nephritis, basically electron is subepithelial deposition. Okay, so membranous nephritis, electron microscope is subepithelial deposition, and you can see membranous nephritis, basically you can see fine granular deposition in membranous nephritis. Okay. Then there is focal nephritis and diffuse nephritis. So basically focal nephritis basically involving focal area of intracapillary and extracapillary region, and diffuse is involving most of the areas of extracapillary and endocapillary. Okay, so this you need to remember. Now remember about class 3. So class 3 lesion, they have most varied course. So basically class 3 lesion have hypertension, active urinary sedimentation, proteinuria is also high, hypertension is also seen and in those patients. So basically this class 3 lesion are most commonly very important lesion which are more of varied course. Okay, there will be elevated serum creatinine in this patient, and obviously mild proliferation responds well to the therapy with steroid alone, and fewer than 5% progress to renal failure over 5 years. Okay, so these are important things about class 3 lesion. Then you have class 4 lesion. So class 4 lesion, what you need to know about class 4 lesion is, so wire loop are seen in class 4. Okay, wire loop are seen in class 4. So commonly very high anti-DNA antibody titer, and there will be low serum complement, and hematuria, red blood cell cast, proteinuria, hypertension and decreased renal functions are the major features which you see in class 4. Okay, so basically there will be proteinuria in this patient, and patient with crescents on biopsy of a rapid progressive declining in renal function. So basically what you get in case of this lupus nephritis. So lupus nephritis you get into endocapillary and mesangial hypercellularity. Okay, so endocapillary and mesangial hypercellularity. So this is mesangial hypercellularity and this is endocapillary cellularity. Okay, so endocapillary and mesangial hypercellularity, and there you can see wire loop lesions. Okay, wire loop lesions, you can see wire loop lesions in case of glomerulonephritis. Okay, so which glomerulonephritis? Lupus nephritis. And basically lupus nephritis, what we have talked when we talk about IF, so IF is lupus nephritis कहाँ पे आता है? So one, it comes in is. So is what? So S is SLE, and basically class 2. So class 2 have, so what is there? Mesangial deposition. So class 2 will have mesangial. So class 2 will have mesangial IF. Okay, mesangial deposition. And when we talk about class 3 and class 4, they are basically associated with coarse granular, COARC, coarse granular linear capillary, coarse granular linear capillary and mesangial. so they are associated with this type of proliferation in cell. So basically you are seeing prominent granular GBM. So with this can be basically this is basically class 3 and 4. This is basically class 3 and 4. So granular electron dense deposits. So where are the granular electron dense deposits? So they are basically subendothelial deposits. Okay, subendothelial deposits. And subendothelial deposits are seen in basically in what? Class 3 and 4. Okay, so these are some of the important thing about different classes of lupus nephritis. Okay, lupus nephritis. And lupus nephritis, one is minimal mesangial nephritis. Then you have mesangial proliferation, that is class 2. Not so importantly, you cannot diagnose that. Then obviously you can have class 3 and class 4, where class 3 and class 4 are basically, class 3 is focal glomerulonephritis and class 4 is diffuse glomerulonephritis. Okay, diffuse proliferative glomerulonephritis and focal proliferative glomerulonephritis. So these are different type of classes which you get. Okay, then class 3 and 4, and after class 3 and 4, that is class 5, that is membranous glomerulonephritis. And obviously class 6 you get basically class 6 is getting sclerosis. Okay, so this is basically all undergone sclerosis. So this have undergone sclerosis, and this is basically class 5 where you get basically class 5 where you get membranous glomerulonephritis. Okay, membranous glomerulonephritis, here you can get double tram track like or double tracks, and also you can get spikes. So GM spikes also you can get. Okay, so in this case of membranous lupus glomerulonephritis. So these are some of the important types of membranous glomerulonephritis. Okay, so now another important thing about lupus is basically we have talked about IgG also, class 2 IgG. We have talked about class 2 IgG. We have talked about class 3 and class 3 and class 4 IgG. Okay, and we have talked about subepithelial deposition in class 5 lupus. Okay, class 5 lupus, we have talked about that. So then another important nephropathy is HIV associated nephropathy. So HIV associated nephropathy, so major things which you get in HIV associated nephropathy will be collapsing glomerulopathy or focal segmental glomerulopathy. So key features about HIV nephropathy is basically there will be segmented or global collapse of the tufts with overlying visceral epithelial cell proliferation. Okay, so visceral epithelial cell will proliferate. So as I talked about basically visceral epithelial proliferation cell, they are the podocytes, and this visceral epithelial cell will proliferate, and hence there will be they can also undergo collapsing. Okay, so that is hence it is known as collapsing glomerulopathy. Okay, then in tubular region there will be microcystic tubular injury. Okay, so microcystic tubular injury with interstitial inflammation. And now remember everybody knows about collapsing glomerulopathy of HIV. Okay, HIV associated nephropathy, they will have collapsing glomerulopathy. So other thing which they can ask about this is reticular aggregate. So in HIV there will be reticular aggregates. In HIV there will be reticular aggregate. That is another important thing which can be asked in case of exam. So differential diagnosis of collapsing glomerulopathy, one is HIV associated nephropathy, that is very much important. Okay, you can also see reticular aggregates in collapsing glomerulopathy, HIV associated glomerulopathy. Okay, then you have idiopathic variant of focal segmental glomerulosclerosis associated with pamidronate or interferon treatment, severe ischemia, it is associated with severe ischemia also, and it can be associated with systemic lupus erythematosus. Okay, so these are some of the differential diagnosis. Now basically after differential diagnosis, HIV nephropathy will obviously they do not show immune complexes deposit, but may also show non-specific IgG and C3. The protein droplets in the podocytes may stain for any IgG including IgG and IgA. The specific location and round globular pattern of this staining allows distinction from immune complexes. Electron microscope, very much important, is reticular aggregate. There will be collapse of tufts and proliferation of podocytes with food process. Okay, and basically this reticular aggregate is related to elevated level of interferon alpha. Okay, so there are high level of interferon alpha, and because of that interferon alpha it will be elevated. So that is again a high yield point which you need to remember in case of electron in case of what we call it so you need to remember in case of HIV associated glomerulopathy. Okay, HIV associated glomerulopathy. So this is about HIV associated glomerulopathy. So what is happening here? So here you are increasing the cellularity. So this is basically visceral epithelial hyperplasia, and this they look like crescent. Okay, they look like crescent, they mimic like crescent. So basically now I am talking again and again about crescent, so now it's time you know about the crescent. Okay, so what is crescent? In case of crescent is basically, it's nothing, at least two layer of cells when they are formed between the basically endothelium or basement membrane of glomeruli and parietal layer of Bowman's capsule. Okay, so Bowman capsule or basically endothelial layer of parietal glomerular capillary, if there are two cell layers, then that is known as crescent. Okay, that is crescent. So crescent from crescent. So basically when we talk about crescent, now this is basically your reticular. So यहाँ पे ये आपका reticular deposition है. This is reticular deposition. This is tubulo-reticular deposition. Okay, so this is tubulo-reticular deposition which you see in case of HIV. Okay, so now basically when we talk about another type one, there is another type of glomerulonephritis also. So basically, which is another type of glomerulonephritis? So there is one more glomerulonephritis. Wait, I'll see just. Rapidly progressing glomerulonephritis. Okay, now it's right time you come forward. Rapidly progressing. So rapidly progressing glomerulonephritis, or what I say, it is crescentic glomerulonephritis. Okay, crescentic glomerulonephritis. So this rapidly progressing glomerulonephritis or crescentic glomerulonephritis, so they will have crescent. So crescent, by now what you need to know about the crescent by now is, so crescent are nothing but they are the two cell layers between the parietal epithelium or Bowman's capsule and the visceral epithelium, or what you call it basement membrane, glomerular basement membrane. Okay, so basically two cell layer, at least two cell layer between these two. So between these two cell layer between the parietal epithelium or Bowman's capsule and basically your what we call it your endothelial cells, glomerular basement membrane. Okay, so basically that is one thing. So now what will be there? So when I am talking about Bowman's capsule, so in rapidly progressive glomerulonephritis, crescent will be basically formed by what? So it will be formed by parietal epithelial cell. Okay, so this is basically proliferation of parietal epithelial cells, with plus mesangial neutrophils, monocytes, macrophages. Okay, so this is basically lymphocytes, fibrins, fibroblasts. So these are basically main components of a crescent. Okay, so basically these are the main components of a crescent. So among these, which of the following is most important component? So among these, which of the following is most important component? So this is, you need to know monocytes. Monocytes are most important component in case of early glomerulonephritis. In case of early rapidly proliferative glomerulonephritis, monocytes are most important components. Okay, monocytes are important component in case of early. Okay, and basically your in late crescent, in early crescent, monocytes are most component, and epithelial cells are most important component in case of late. In case of late crescent, epithelial cells are most important component and monocytes are most important component in early crescent. Okay, so that you need to know. Then what you need to know about that is crescent, they can be two types. So they can be cellular crescent, or there can be fibrillary crescent. Okay, so cellular crescent, so this is fibroblastic or cellular crescent. So cellular crescent is basically you have high amount of cellularity like monocytes and all, and fibrin. Okay, cellularity of monocyte, neutrophils and all, plus fibrin. Now here you have myofibroblast. Okay, here you have myofibroblast in high amount. Okay, so this basically are fibrillar or fibroblastic, what you call it. So now crescent, when you talk about crescent, so crescentic glomerulonephritis, So crescentic glomerulonephritis or rapidly progressive glomerulonephritis or crescent glomerulonephritis. Okay, so this rapidly progressive, this can be type 1, type 2, type 3. They can be type 1, type 2 and type 3. Okay, they can be type 1, type 2, type 3. So type 1 are basically your so they are divided according to what we call it immunofluorescence. Okay, divided according to your immunofluorescence deposition. Okay, so basically type 1 are your linear capillary deposition, IF deposition, linear capillary deposition or IF, or basically we call it anti-GBM. Now by name linear capillary deposition किस में होता है, anti-GBM में ही होता है, ठीक है. So basically this is type 1 rapidly proliferative glomerulitis. Type 2 proliferative glomerulitis, granular capillary glomerulonephritis. Okay, so basically in this what you call it granular. So in the granular what you have all your MPGN, lupus nephritis, even membranous nephritis. These are the differential diagnosis of type 2 rapidly progressive glomerulonephritis or crescentic glomerulonephritis. Okay, so lupus glomerulonephritis, Henox-Sclein glomerulonephritis, MPGN, cryoglobulinemia, endocarditis associated glomerulonephritis. So whatever I have given you some differential of MPGN and whatever we have talked about lupus or MPGN, all they are rapidly progressive glomerulonephritis type 2. So now rapidly progressive glomerulonephritis, why that name rapidly progressive glomerulonephritis? क्योंकि वो they are clinically, when you talk about them, they are progressing rapidly. Okay, so clinically they progress rapidly towards the acute renal failure side. So this is hence you call it rapidly progressive glomerulonephritis. And pathologically they are basically characterized by characteristic immune deposition. Okay, so type 1 you have linear capillary immune deposition, type 2 you have granular capillary immune deposition, and type 3 they are the pauci-immunes. They are pauci-immune. Okay, type 3 are pauci-immune, that is they have very less amount of immune system deposition. So they are pauci-immune. Type 3 are pauci-immune. Okay, so without deposition of immune, and this pauci-immune they are classified according to NK positive and NK negative. Okay, so now this pauci-immune again are classified again to NK positive and NK negative. Okay, so pauci-immune, this pauci-immune are classified into NK positive and NK negative. Okay, NK positive and NK negative. So in NK positive, what do you need to remember about the NK positive? Anti-neutrophil cytoplasmic antibody. So what is in this? These are basically polyangiitis. So what type of polyangiitis? So one is basically your microscopic polyangiitis. Another is granulomatosis with polyangiitis. Okay, granulomatosis with polyangiitis is Wegener's granulomatosis. Okay, granulomatosis with polyangiitis. Another is your eosinophilic polyangiitis. So eosinophilic polyangiitis is Strauss syndrome. Stroke syndrome. Okay, so these are basically NK positive glomerulonephritis. So NK positive glomerulonephritis is basically polyangiitis. One is microscopic polyangiitis, another is granulomatic polyangiitis, that is Wegener's granulomatosis, and another is eosinophilic eosinophilic granulomatosis polyangiitis, which is Strauss syndrome. Okay, so these are NK positive in case of and this NK positive, they are pauci-immune glomerulonephritis which you see in nephritis. Okay, so this we will do this type 3 or rapidly progressive glomerulonephritis. So this way they are classified as type 1, type 2 and type 3. So we will do this or we will continue this in next class of glomerulonephritis. Here we are getting lot of disturbance today, so कोई शादी हो रही है. So basically again before signing out, I like to say you please you can just subscribe to this our channel Unacademy our channel, and you can subscribe to this Unacademy NEET PG, and obviously you can subscribe Okay, you can subscribe to this Unacademy channel, and you can just how you can subscribe. Basically, you can subscribe by downloading or by installing Unacademy Learning app, and hence you can just check out NEET PG, and obviously you can select the plus stream and get subscription, and you can use my live code ANLIVE. So this will help you to get 10% discount. Have a great day, and bye bye. See you in next class. Basically, we'll talk about the remaining glomerulonephritis, and basically we'll try to finish those of everything. So basically, if you go and remember that first table which I teach you, and basically for IF you remember daddy's MLA, and basically you remember what are all the subepithelial and subendothelial deposition. Glomerulonephritis is very easy topic. Okay, glomerulonephritis is a very easy topic. So we'll talk about this again in our next class. Have a great day. Good night. See you again. Thank you very much.